Alterations in elimination, gastrointestinal, disorders of the liver, gallbladder, or pancreas. The liver has 4 lobes, and it's supported by mesenteries that help connect the liver to the intestines, abdominal wall, and diaphragm. It metabolizes glucose, proteins, and fats, drugs, chemicals, bacteria, and foreign elements. It also converts glycogen to glucose, regulates blood glucose, stores vitamins, forms and excretes bile and bilirubin, synthesizes factors for blood coagulation. Liver function is not significantly affected unless disease is present in the older adult. Jaundice is a greenish-yellow discoloration of tissue. It's not a disease process, but it is a symptom of disease. It results from an abnormally high concentration of the pigment bilirubin in the blood. It is visible, notably on the skin, oral mucosa, and especially the sclera. There are 3 forms of jaundice. We have hemolytic jaundice from excessive destruction of red blood cells, hepatocellular jaundice from liver disease, and obstructive jaundice from blockage of the bile between the liver and the intestinal tract. So true or false? Jaundice results from an abnormally low concentration of the pigment bilirubin in the blood. And this is false. So cirrhosis is a chronic degenerative liver disorder caused by generalized cellular damage. We see irreversibly damaged liver cells, and the consequences of those damaged cells will affect digestion and metabolism, fluid and electrolyte imbalances, and the impaired ability to metabolize hormones and detoxify chemicals. There are several types. Alcoholic is the most common, and it's caused by chronic alcohol intake or poisoning or ingestion of hepatotoxic drugs such as acetaminophen. Postnecrotic, which is destruction of liver cells secondary to infection, disease, or exposure to hepatotoxins. Biliary, which is scarring around the bile ducts in the liver from chronic biliary obstruction and infection or autoimmune liver disease. And we also see non-alcoholic steatohepatitis, which is a buildup of fat. The prognosis for cirrhosis will be dependent on the bilirubin and albumin levels, ascites, neurological involvement, and nutritional status. These clients may be compensated or decompensated. We may see chronic fatigue, anorexia, dyspepsia, nausea, clay-colored stools, and diarrhea, along with constipation, tea-colored urine, weight loss and abdominal discomfort, and shortness of breath, nosebleeds, signs of incomplete estrogen metabolism in men, along with an enlarged liver or spleen, and jaundice. We diagnose with a liver biopsy, blood tests, CT scan, MRI, radioisotope liver scan, can help demonstrate the liver's enlarged size, any nodular configuration, or distorted blood flow. There is no specific cure for cirrhosis. However, we try to prevent further deterioration. Provide vitamins and nutritional supplements, encourage no alcohol, advanced liver disease, restrict the protein intake, and maybe administer lactulose. Ursodeoxycholic acid, potassium-sparing antidiuretics, sodium intake may be regulated. We may be doing platelet transfusions or liver transplantation. Nurses should monitor vital signs, weight, eyes and nose, abdominal girth, encourage small meals and skin moisturization. The client's response to drug therapy, including observing for a change in mental status and signs of GI bleed. Provide client teaching for liver disorder, support groups, treatment regimen, and home care. Complications of cirrhosis include portal hypertension. This is where the blood backs up in the portal system and we see congestion, pressure, GI bleeds, ascites, and encephalopathies. We treat with sodium restriction, drug therapy, and a surgical or non-surgical shunt. Esophageal varices are a result of portal hypertension that causes dilated, bulging esophageal veins that are easily traumatized and can cause severe, life-threatening esophageal bleeding. It can be treated with sclerotherapy, a variceal band ligation, or a Singstaken-Blakemore tube. We can also administer IV fluids, blood products, and encourage a soft diet. Ascites is another complication, and it's a collection of fluid in the peritoneal cavity. It comes from the hepatorenal syndrome, and we see serum protein that has built up in the peritoneal cavity in this fluid. Abdominal paracentesis would include surgical insertion of a catheter into the abdomen, diet, and drug therapy. Hepatic encephalopathy is a CNS manifestation of liver failure. It may also lead to coma and death. And there's an increased ammonia level. Encephalopathy, there we go. These clients will have the CNS effects such as disorientation, confusion, personality changes, and asterixis. We treat it by eliminating dietary protein, administer lactulose, that helps remove residual protein, and deplete intestinal microorganisms. Hepatitis is liver inflammation after exposure to drugs or chemicals, alcohol abuse, or infection, and it can be acute or chronic. It can come from a viral infection, and that would include hepatitis A, B, C, D, E, and G. Hepatitis A and E is transmitted through an oral fecal route. Hepatitis B and C is transmitted through blood transmission. Hepatitis G follows a blood transfusion. Hepatitis B, C, and D are chronic and persistent, and B and C are involved with hepatocellular carcinoma. Other types of hepatitis include autoimmune, toxic, or drug-induced. These clients in the incubation phase may be asymptomatic. The virus, however, is found in the blood, bile, and stool, and they are infectious at this time. In the preecteric or prodromal phase, the client will experience nausea, vomiting, anorexia, fever, right upper quadrant pain, rash, and urticaria. With the ecteric phase, the clients will have jaundice, pruritus, clay-colored stools, dark urine, and fatigue. In the post-ecteric phase, we see liver enlargement, malaise, fatigue, liver tests that begin to return to normal. We diagnose through a serology analysis and a liver biopsy. Treatment involves bed rest, symptomatic treatment, IV fluids, balanced diet, vitamins, and antiemetics, in addition to other drug therapies. May require liver transplantation, which would then require immunosuppressives. Nursing management involves teaching transmission prevention, teaching complication prevention, and teach the client to avoid alcohol and liver toxic medications. So which type of hepatitis is passed by the oral fecal route? That was type A. Liver tumors are abnormal masses of cells located in the liver, and they can be benign or malignant. It may be a primary tumor, meaning that's where it started, or a metastatic lesion that comes from the breast, lung, or GI tract. Benign liver tumors can be found as a result of tuberculosis or fungal and parasitic infections. They can cause bile obstruction, jaundice, liver failure, portal hypertension, and ascites. These clients may be jaundiced, have right upper quadrant pain, liver enlargement, again, ascites. We diagnose with blood tests, liver scan, ultrasound, MRI or CT scan, and liver biopsy. We can treat this surgically or medically. Surgically, we may have a hepatic lobectomy, cryosurgery, or a cryoablation. We may also do IV chemotherapy or infusions that are directly infused into the hepatic artery or peritoneum, and other drug therapies. We can also do chemotherapy or radiation therapy. Nurses need to ensure client safety and comfort, excuse me, support their ventilatory system, teach medication administration, and provide support and referrals to the client and family. Gallbladder disorders include cholelithiasis, which are stones in the gallbladder, cholelithiasis, which are stones that are located in the common bile duct, and cholecystitis, which is inflammation or infection of the gallbladder that's caused by the formation of stones, and it can be acute or chronic. Risk factors for gallbladder disorders include the 5 F's: female, fat, fair, 40, and fertile. The risk also increases if the client is diabetic. These clients experience bile stasis. There may be some dietary factors involved or infection. We do know that gallstones can impair the passage of bile. The gallbladder will be inflamed and distended with bile. These clients experience belching, nausea, vomiting, discomfort that's the result of inflammation and contractile spasms, especially after high-fat meals, from reduced or absent bile. There may be swelling or even a necrotic gallbladder. These clients may experience some jaundice or light-colored stools. We diagnose with a cholecystography, CT scan, ultrasonography, radionuclide imaging, a PTCA, an ERCP, or an MRC. We treat with an NG tube, antibiotics, parenteral fluids, low-fat diet, lithotripsy to help break up the stones, sphincterotomy, or a laparoscopic or open cholecystectomy, and a T-tube may be inserted to help drain bile. Nurses provide appropriate pre- and postoperative care, drain care, teach the client to avoid high-fat foods, and teach them about any medications. Pancreatitis is inflammation of the pancreas, and it can be acute or chronic. Acute pancreatitis is a mild form, and we see inflammation and edema of the pancreas. In the severe form, there's enzymatic digestion of the pancreas. necrotic tissue, and local and systemic complications. So with pancreatitis, there's autodigestion from a reflux of bile and duodenal contents. We see a swelling of the pancreatic duct and destruction of the pancreas. It can be caused from structural abnormalities, abdominal trauma, infections, irritable bowel disease, and alcohol intake. These clients experience severe mid-abdominal to upper abdominal pain radiating to the sides and the back that increases after eating. They may also have vomiting, frothy and foul-smelling stools, signs of steatorrhea, which is increased fat in the stool, jaundice, hypoactive bowel sounds, and hypotension. We diagnose with an elevated serum and urine amylase, lipase, and liver enzyme levels. We may also see elevated blood glucose levels and white blood cell counts, low serum electrolyte levels. We can also diagnose with a CT scan or endoscopic examination. With chronic pancreatitis, causes can be from alcohol, a hereditary predisposition, hyperparathyroidism, autoimmune pancreatitis, trauma, and anatomic abnormalities. These clients may experience severe and persistent pain, digestive disturbances such as flatulence, vomiting, diarrhea. They may have dark urine or secondary diabetes, light-colored stools, and weight loss. We diagnose with CT scans, MRI, ultrasound, and endoscopic retrograde studies. Treatment would include abstinence from alcohol, fat-free diet, and correction of associated biliary tract disease. Drugs may include meperidine, narcotics, non-opioid methods, and pancreatic enzymes. We may see a partial or total pancreatectomy. Nurses should monitor for life-threatening symptoms and monitor glucose levels and I's and O's. Pancreatic cancer can occur in the glands, head, body, or tail. We see an accumulation of malignant cells that block the pancreatic duct and cause symptoms that are similar to chronic pancreatitis. There is a rapid growth and usually a poor prognosis with pancreatic cancer. Factors that correlate with pancreatic cancer include diabetes, a high-fat diet, and chronic exposure to carcinogens, excessive body weight, or a family history. These clients' disease may be far advanced before any symptoms are noted, but the symptoms would be left upper abdominal pain, jaundice, anorexia, weight loss, obstructive jaundice, pruritus, ascites, light-colored stools, and dark urine. We diagnose with abdominal ultrasonography, CT scan, or a biopsy. We can treat it with ablative procedures. We may do a radical pancreatoduodenectomy or Whipple procedure. This procedure actually removes the head of the pancreas and resects to the duodenum and stomach, redirecting the flow of secretions from the stomach, gallbladder, and pancreas. We can also do a cholecystodugenostomy, which is a rerouting of the pancreatic and biliary drainage. And for inoperable tumors, radiation therapy or chemotherapy may be done. Nurses provide palliative care, postoperative care, or prevention of complications. We monitor for bleeding and infection, and teach clients on their medications and how to monitor their glucose levels. So true or false? A Whipple procedure is going to be the removal of the head of the pancreas with resection of the duodenum and the stomach and redirection of the flow of secretions from the stomach, gallbladder, and pancreas. This is true.